Hey, look, another article that shows that ketamine is more effective than fentanyl. Isn't that crazy? Today on Magic. Hey, everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here. How we doing, Danny?
I'm good. How you doing? How was your holiday and everything?
It's going good. It's going good. We're here in the holiday season in New Jersey, and it's the best. And as our gift, we're going to talk about another paper we found that it shows that ketamine might actually be efficient after all, because nothing is consistent and nothing makes sense. So
everybody knows ketamine is our favorite drug. We love it. If it had antibiotic properties down the road, I would totally believe it. So let's get into it. We found another thing that shows ketamine's doing really good stuff.
Yeah, and this is a study that came out of Egypt. And what they looked at was the hemodynamic effects of ketamine versus fentanyl when they bolused patients in septic shock. So this is a very, very specific paper, right? This doesn't talk about, traumatic situations. They're just looking at sepsis.
Right.
And the N in this study is a little bit small. It's 86 patients. But really what they looked at was cardiac output, stroke volume, heart rate, and mean arterial pressure, which is important because this is something that they were looking at it in septic shock, but it's also data that can be extrapolated to other conditions. So really, in a nutshell, what they ended up finding was after they gave ketamine to these patients, they were measured at baseline 3, 6, 10, and 15 minutes after the intervention, and they checked the changes in all these parameters: cardiac output, heart rate, stroke volume, and MAP. And it turns out that ketamine improves all of them, especially over fentanyl. So seeing this, and we know about ketamine's hemodynamic effects, right? That's been elucidated in the data. We know that ketamine, can improve all of these things, but it's nice to actually see this published. And this came in this is early from 2024. This is from this month, out of the Journal of Anesthesia. Brandy new. And what's interesting about it is they're looking just the things that they're looking at, right? They're not looking at pain management. They're not looking at pain control. They're just looking at the physiologic parameters that occur after you give ketamine.
Yeah, exactly. That's what I really liked about this study, is that this was a very technically focused study. They measured stroke volume, they measured heart rate, they measured MAP, they calculated cardiac output, and they did it multiple times after the administration of each drug. And they were able to measure the delta in cardiac output, which we all know is change. I think this was a really well set up study. I know the number's a little small. People say it's underpowered. Yes, but this is a really interesting finding. And if we can replicate this on a regular basis, I think we're onto something, that ketamine given to the right populations under the right circumstances is very safe, is very effective, and can help with your shocky cardiac output depleted patients.
And the other important thing in this study is that, again, they didn't look at reasons for receiving fentanyl or ketamine. Right. It was a simple, you got X, this is what happened. And that's something that I really appreciate about this study, because, again, what they were looking at was patients in septic shock. So we already know they're hemodynamically compromised. These are patients in the field. Now, again, this is an in-hospital study. This is not a pre-hospital study. So how do we apply that to EMS? This is a randomized control trial. So if you're looking for a septic shock patient, you have to intubate them. You have to perform an RSI procedure. This supports ketamine over fentanyl. If you have to manage their pain for whatever reason, this supports ketamine over fentanyl. If you have to just sedate the patient so septic shock can also present with altered mentation, and maybe the patient is agitated or aggressive. This supports ketamine over fentanyl. Again, small data, small study. We in the United States are not very good at accepting international data. And that's kind of another roadblock that I think tends to occur, because if it doesn't happen in America, then it's not good. But
America, I
think the reality exists that the ketamine in Egypt is probably just as potent as the ketamine in America.
Maybe. And, if you go from the perspective of most things in medicine are administered as a loading dose and then a maintenance dose. And if you look at ketamine here as a loading dose to achieve sedation, you're in a pretty good spot. You're not going to do a lot of harm to your patients. The p-value is very good. This is not a bad study at all.
Yeah. And again, it's not entirely encompassing. And that's kind of one of the fun things about data, right? Is that one study is one study. We've mentioned that several times on the Journal Club before. But looking at this kind of data and then taking it in the totality of your patient's presentation, right? If I've got someone who's in a shock state, and by definition, they're going to be hypoperfusic, right? So when we're in the field, we know like we're giving fluid, right? Because even though we know that we have to kind of reduce the amount of fluids we give in sepsis, we're still giving fluid in the field, right? And when you have these parameters that show like, all right, well, all this patient's cardiac output, their heart is just not doing the thing it's supposed to do. How do we support those efforts? And I think we tend to just give fluid first to increase preload. I don't know that we give enough medication to really augment blood pressures, right? Because in septic shock, we talk about giving phenylephrine, we talk about giving, all these alpha pressors. We've kind of gotten away from dopamine and dobutamine, and all that is great.
I think you're seeing in sepsis, you're seeing a lot more places that are going to norepinephrine or epinephrine as a pressor. I think the idea that you can only give these through a central line is pretty much debunked, except, even the first couple hours. As more shops take on the idea of, hey, let's go pressor first, give a little bit of fluid, I think you're going to see that that's a good thing. But this is very good in this situation, to tell you that, hey, fentanyl's going to do some good things for your patient. You should probably think about it. Now, what we need to do is we need to take the work these people did, and kudos to them, and we need to replicate it on a regular basis. So this would be a great study for an EMS service to jump on and kind of look at how they set it up, do it in the field or do it with your emergency department and see if you can replicate this data, because the precedent's there. It's not something that's going to be a danger to patients. Now we just have to see more of this to kind of reinforce our position.
And yeah, I think that's right. And again, this doesn't talk about, I guess, the other comorbidities that's involved in sepsis, right? So there's always going to be more research needed to show how this constellation of treatment actually works in this particular setting. But if we're worried about how we're going to treat these patients, right, which is always like, pressor, fluid, whatever else, here we have something that's kind of just established where, all right, you have a septic patient, let's say they're about to lose their airway. And you're not really sure if you need to augment their blood pressure with pressors or if you have to give them fluid. Here we have something like, okay, in this very, very specific scenario, right? You have a septic shock patient that you have to intubate and you're debating what you're going to use. This kind of supports giving ketamine over fentanyl in, let's say, an RSI procedure. Now, this isn't to say that you shouldn't use all these other things, but keep in mind that ketamine has analgesic properties on top of its sedation properties, which is one of the reasons that we love it so much, where it's kind of a drug you can give for everything. It has anxiolytic properties. It has all these things, which can just make people better.
It is a great agent to use in the field, especially in an RSI situation when it's given appropriately. It will do a lot of things for you. It will make your RSI procedure a lot cleaner with less drugs to give, less switching around of vials, moving things around. I think there's a benefit to that, especially pre-hospital. And like you said, this is one snapshot looking at people where we're sedated and anesthesia was induced with septic shock. And this showed you didn't have a drop in cardiac output, which is something that dangerously is deadly. This can be a clean kill. You didn't see that from this group as opposed to the control.
Yeah, that's all correct. So we really like this study, and we also really love ketamine. Soundbite, be sure to clip that out of context and send it to our employers. But for the Monday afternoon, don't do that. But for the Monday Afternoon Journal Club, Ed Bowder and Dan Schwester, be sure to like and subscribe to all of our stuff. Listen to our podcast. Check us out on Spotify, Apple Podcasts, and on YouTube. And we will talk to you next week.
Take care.